Bismillahir Rahmanir Rahim. Qalu subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. We started with these lectures of balance. So far we have taken 2 lectures on the fluid and electrolyte balance and 1 lecture on the basis of acid-base balance. And I have discussed the physiological basis of acid-base balance also. So there are 3 steps in diagnosing the acid-base disturbance. First step is to diagnose the acid-base disturbance. Second step is to assess the oxygenation status. And the third thing is to look at the hemodynamics of the patient and the perfusion, peripheral perfusion status of the patient. So we pass through the two phases, and the third one we will be starting today. Now, if somebody asks you, what is the oxygenation status of this patient? What is included in that? You have done the acid-base disturbance evaluation, and you know this patient, some patient is suffering from metabolic acidosis, whether it is a metabolic, compensated or uncompensated, or respiratory problem, compensated, uncompensated, whether it is a alkalosis in that way. But when they ask you what is the oxygenation status of a patient, although the oxygenation does not come into action as far as the diagnosis is concerned, diagnosis of first step includes only 3 things, as we discussed last time. First thing is a pH that gives you information about the acid-base status. And then 2 steps downward, next is a PCO2. That will tell you whether this is a causative factor of disturbance or not. Then the third thing is you look at the bicarbonate, whether this is a causative factor of disturbance also. If the causative factor is PCO2, so this is a respiratory cause. If it is a bicarbonate, it is a metabolic cause. So you have done up till now to this. Then oxygenation status, you look at first of all, you look at how much oxygen you are giving to the patient. That is called FiO2. That is fractional inspired oxygen concentration. But under what pressure it is going in? You calculate the PiO2. Then the same oxygen goes into the alveoli. Then it exerts its pressure, and that is called P big AO2. And then the blood gases passes through, oxygen passes through the alveolar capillary pathway, goes into the plasma. Then exerts its pressure over there, which is called P small AO2. Under that pressure, this oxygen combines with the hemoglobin, and that is called percent saturation of hemoglobin. Then bulk of the oxygen is carried by the hemoglobin, and this thing then is delivered to the tissue. From there we calculate how much is being delivered. That's called DO2, delivery of oxygen. Then how much is extracted by the tissues. So we'll have to take the venous sample, then look at the DO2 of arterial blood and DO2 of venous blood. Whatsoever is the difference, that is the amount which has been taken by the tissues. Now the next step is oxygen has been taken by the tissues, whether the tissues are using it or not. To look at that, we have to see whether there is anaerobic metabolism going on or aerobic metabolism going on, even if the oxygen is sitting there, even if the oxygen is extracted. So if it is anaerobic metabolism going on, then we look at the lactate, if it is anaerobic metabolism. Once you have assessed up to the level of lactate, it means you have assessed the oxygenation status of patient. FiO2, PiO2, P big AO2, then P small AO2, then percent saturated hemoglobin, amount of hemoglobin, then DO2, then VO2, and the extraction ratio, then look at the lactate. If you're done up to that, then the person who has asked you the question, he will satisfy that you have assessed the oxygenation status. If you look at the blood gas report in our ICU, it gives everything in that. You, one by one, all the steps you should clarify yourself. But once you have done, looked at the acid-base status of a person. So the first step is acid-base status, and then second is the oxygenation status. Now, for your practice, I have given a few figures here. You look at the pH, then you look at the PCO2, then you look at the bicarbonate. This will assess the acid-base status of a person. If the pH is 7.24, PCO2 is 32, bicarbonate is 14. What is this? You analyze these things in the same sequence. Never try to answer the question very quickly. Take your time, analyze one by one. pH 7.24, what does it show? It is less than 7.4, so this is showing acidosis. And it is outside the compensatory range, which is 7.3. So it is acute acidosis. Then you look at the PCO2. The 32 PCO2, can it cause acidosis? Because a normal PCO2 should be 40. If it has to be by a respiratory element, it should be greater than 40. So it is less than 40. Then you go to bicarbonate. Bicarbonate normally is 24 to 26 or 22 to 24. So this is 14. It's very less. So it means this is the causative factor. So it is metabolic acidosis. But has the compensation started or not? pH is still outside the compensatory range, because the compensatory range of acidosis from 7.3 to 7.5, and exact pH should be 7.4. So it is outside 7.3, so it means it is uncompensated. But as it is a metabolic element, you look at the PCO2. PCO2 should be 40. It means the patient is washing out CO2. It means compensation has started. So this is partially compensated metabolic acidosis. Then you look at the base excess. It's a severe acute condition of metabolic acidosis, minus 13. Normal should be plus minus 1. Then you look at the PO2, is 100. And you're taking 21% oxygen, room air. And age is 40. At this age, PO2 is normal at 20% oxygen. It means the patient has got partially compensated metabolic acidosis. Hypoxemic status is normal. He is not hypoxic. So this should be the diagnosis of this figure. The same way you look at the other ones also. I have given you handout and you do the copies and practice yourself. Okay? Because usually it takes 1 month to complete the practice. But unless you sit down and look one by one on each step, you cannot become expert on blood gas analysis. So you should take time. Don't jump on the diagnosis. Same way the next one is pH is 7.42. PCO2 is 28. Bicarbonate is 80. What is it? pH is 7.42, that shows alkalosis. Then the PCO2 is for 28. Can it cause alkalosis? Yes, it can cause alkalosis. But then you look at the bicarbonate, 18. Can this cause alkalosis? No. If it has to do, it should cause acidosis. So it means it is a respiratory alkalosis. Now, then you look at the base excess is minus 5. Right. Then you look at the PO2 is 50. And FiO2 is 40. And age is 50. At age of 50, acceptable PO2 should be 80. But it is 50. From 80 to 60 is the mild hypoxemia. From 60 to 40, it is a moderate hypoxemia. It is a moderately hypoxemic. In spite, we are giving 40% oxygen. So this should be analysis like this. Then try to find out the cause. Why? What is the causative factor of acid-base disturbance? So all these figures has been given in the handouts and you can practice yourself. There are some more also like this. The third step is assessment of tissue oxygenation, because the whole objective of learning this acid-base disturbance and hypoxemic state is whether oxygen is reaching to tissues or not. For that, the third step is very important also. So for assessment of tissue oxygenation, you look at the cardiac status of a patient. Then you look at the peripheral perfusion. Then you look at the blood oxygen transport mechanism by the hemoglobin. So it means you will have to look at the vital sign and you will have to do the physical examination also. As far as the cardiac status is concerned, you look at the blood pressure, systolic blood pressure, diastolic blood pressure, pulse pressure, and mean arterial pressure. So every component of blood pressure is very important. Systolic has got its own importance, diastolic has its own importance, mean arterial pressure has its own importance, and pulse pressure has got its own importance. And try to analyze it. Then you look at the heart rate, whether it's a normal heart rate or compensating heart rate. Then look at the ECG, skin color, capillary refill. This is a part of hemodynamic assessment, capillary refill. Right. Then sensorium, electrolyte balance, and urine output per hour, how much is urine being produced. If above 1 and 2, which I have mentioned, they are all right, then you look at the oxygen carrying mechanism. That depends on the arterial oxygen tension, and it also looks at the blood oxygen content. And we also look at the hemoglobin affinity, oxygen affinity also. Because when the oxygen goes into the plasma, it has to combine with the hemoglobin. Because saturation doesn't tell you much. Saturation only tells you that oxygen you are giving is passing through the alveoli, going into the blood, and combining with the hemoglobin, irrespective of the amount of hemoglobin you have got. If you got 4 grams of hemoglobin, it can give you 100% saturation. If you got 14 grams of hemoglobin, it still can give you 100% oxygen. But the quantity of oxygen which has combined and in the blood entirely depends on the amount of hemoglobin. For 1 gram of hemoglobin, the 1.39 mils of oxygen should be combined with it. Then you calculate, and the DO2, the total amount which is delivered to tissue, it depends on the hemoglobin also. Then it also depends on what is the hemoglobin's mood, whether its hemoglobin is ready to accept it or not. So then you look at the oxygen dissociation curve. There are 3 factors which affect the oxygen dissociation curve. We'll discuss that later on. So then whether hemoglobin has got affinity for oxygen or not, it depends on oxygen dissociation curve also. There are 3 factors which affect it. One is temperature, other is acidity or alkalinity, and third is level of diphosphoglycerate, 2,3-DPG, diphosphoglycerate. That is a metabolic product of this Embden-Merhoff pathway, if you look at that. So there are sites and the combination for the hemoglobin to oxygen to combine with the hemoglobin and to compete with the 2,3-DPG. There are specific sites where the oxygen has to sit. If the 2,3-DPG is sitting there, if the concentration of 2,3-DPG is greater, so there will be less space for the oxygen to combine with it. It could be other way around also. There could be less 2,3-DPGs and there is more site for oxygen, as that's what happened in the neonates. In the neonates, you got less affinity for 2,3-DPG. So there is more sites available for oxygen to combine with it. So it means the oxygen dissociation curve, except it gives you very good saturation, and it will suck the oxygen from the plasma and it will load the PO2. That's why the neonatal PO2, 40 to 70, is taken as a normal, 40 to 70 millimeter mercury. In summary, you assess the acid-base status, then you assess the hypoxemic state of the patient, then you assess the tissue oxygenation status, then try to find out the cause and see for the need of bicarbonate therapy or not. So these are the 5 steps which we do at the end. You look at the acid-base status, that is looked only by looking at the pH, looking at the PCO2, looking at the bicarbonate. Then assess the tissue oxygenation, so which we have just mentioned. Then try to find out the cause. Okay, what could be the cause? It's very easy to differentiate between the different causes. Then see for the need of bicarbonate therapy. If it is a metabolic problem, then we will have to neutralize the acidity. If it is very much marked acidity, then we give them soda bicarb. So there are indications how to do it. In a summarized way, in metabolic acidosis, you look at the blood urea. If it is increased and the potassium is increased, so it is a glomerular failure. No, it can't be any other cause. Then you look at the blood glucose ketones. If ketones are increased and the potassium is increased, so it is ketoacidosis. Then you look at the serum bicarbonate, PO2. If the PO2 is low, potassium is raised, so it is lactic acidosis. Then you look at the serum bicarbonate. If serum bicarbonate is low, only there might be history of bicarbonate therapy. We have given too much bicarbonate to the patient. If the potassium is increased and if the serum bicarbonate is increased and potassium is increased, think of ammonium chloride therapy. So that are the ureter transplantation into the gut. So that can give you idea. It is a hyperchloremic, nor hyperkalemic, hyperchloremic metabolic acidosis. Now, if the chloride is increased and potassium is low, think of acetazolamide therapy. I've mentioned 9 causes of metabolic acids, and that's how you can analyze them. Then, if the chloride is normal and potassium is low, it is a proximal tubular failure. Then try to find out what are the different causes which affect the proximal tubule. So, in my opinion, I don't take the help of anion gap, as it was mentioned last time by doctor. Anion gap, even American doctors, so we discussed so many times, they always say anion gap, anion gap. Anion gap confuses you. There are only 9 causes of metabolic acidosis in the body. Out of 9 causes, 4 to 5 are lying in the kidney. You can easily differentiate them. If you know the chloride level, if you know the potassium level, then the normal acid-base status of patient, you can easily differentiate between them. What is the causative factor? Now, if considering these things, there are, again, you can do the practice. pH is 7.25 and PCO2 is 40, bicarbonate is 20, sodium is 130, potassium is 5.5, chloride is 100, urea is 95, glucose is 120. Now this is another picture. You are sitting as a consultant or you are senior nurse sitting there and you look at this figure. I've taken the oxygen out, I put the electrolytes there. It will help you to diagnose. pH shows 7.25. That shows acidosis, and it is acute acidosis because it's less than 7.3. Then you look at PCO2. PCO2 is normal. Then bicarbonate is 20. It is very much low. So it is an acute metabolic acidosis. Then you look at the sodium. Sodium is slightly low, but sodium is not main factor. Then potassium is slightly raised. Chloride is normal. And then urea is raised and glucose is raised. So what does it mean? Glomerular failure. There can't be any other cause. Glomerular failure. If you carefully analyze each parameter, you can reach to diagnosis. Then next one is 7.29 pH, PCO2 is 35, bicarbonate 20, sodium 135, potassium 4.5, chloride 118, and urea is 40, glucose is 90. So you can practice these while sitting in your room, and you got all in your handouts and you can analyze instead of me spending the time on it, right? Then we come to buffer base and base deficit. Now, what is the buffer base or what is the base deficit or base excess? The total number of buffer anions in the body are 45 to 55 milliequivalent per liter. If this is less than 45, it means it is base deficit. If it is more than 55, it means it is a base excess. It's not an absolute negative thing we say base excess. So from here when you have got ABG in front of you and you want to calculate predicted respiratory pH. So if you look at the PCO2, if you increase the PCO2 by 20 millimeter mercury, it will have an effect on the pH of 0.1. On the other hand, if you lower the PCO2 only 10 millimeter mercury, it will increase the pH 0.1. So it means little bit of lowering will affect more pH than double the increase of. It's very important if the ABG is in front of you and there is a mixed picture, you will have to see how much is the respiratory element in it, how much is the metabolic element in it. So usko aap analysis karne ke liye you will have to do some calculations. For example, if the pH is 7.21, PCO2 is 90. What will be the predicted respiratory pH? You take the difference of PCO2, 90 is of this patient, it should be 40, the difference is 50. You move 2 decimal towards the left. So you write 0.50. As it has increased, because it will have, if you lower by half or 50%, you multiply it 1 by 2, and it will have an effect on the pH of 0.25. The normal pH should be 7.4, then you subtract 0.25, so it should be 7.15. So the predicted respiratory pH should be 7.15. It's very easy. Another example is if the pH is 7.47, PCO2 is 18. Now here you take the difference of normal PCO2 and estimated PCO2. 40 minus 18, it's a 22. Move 2 decimal towards the left, it will be 0.22. This you add to 7.42, so it becomes 7.62. So if it would happen purely respiratory alkalosis, then the pH should have been 7.62. But the pH is 7.47. So it means the rest is a metabolic element. So that's how you do. You calculate the respiratory pH and then from the indicated one, you take the difference, that will be metabolic pH, that will be metabolic complication, a metabolic effect. But that's not needed. Up to the step which I have already indicated in 2 lectures, if you go up to that step, that sorts out everything. The people go further ahead also for academic purpose. Now, metabolic pH change is equal to measured pH minus predicted respiratory pH. As we have just calculated, the difference will show the metabolic pH. Example is pH 7.04, PCO2 is 76, and you calculate the predicted pH, and then you calculate the base excess also. I don't want to confuse you. And then at the end you calculate the component, metabolic component and respiratory component. Then some other calculations some people have given in the books also, relations of PCO2 to bicarbonate. If you want to indulge into that, respiratory acidosis expected bicarbonate is equal to 24 plus 0.1 multiplied with PaCO2 minus 40. Don't confuse yourself with these things. These are written in the books, that's why I'm mentioning it. Now, this diagram is very important because if you look at the sodium and potassium, these are the 2 electrolytes we estimate every day. There is no secretions in the body which has got sodium level greater than that of plasma level. Normal plasma level is 140. You got gastric secretions, they have got 140. You got biliary secretion, the level of sodium is 60. Then you've got pancreatic secretion that has got level of 40. And intestinal secretion has got 110. So all these secretions, sodium level less than that of plasma. It means if they lose all these secretions, they can never go into hyponatremia. They can go into hyponatremia only if you give this sodium-free fluids or fluids which have got less sodium, like Flavolite M or something like that. So that will lower the sodium. Otherwise, they cannot go into hyponatremia. On the other hand, all the secretions have got potassium level higher than that of plasma. Like gastric secretion has got 4, biliary has got 10, pancreatic has got 5, and small intestine has got 5, then ileal 120, then ileostomy 130, diarrhea 60, sweat 60. It means when you're losing this secretion, you tend to go into hypokalemia. So always remember these two things, sodium and potassium. Whenever there is vomiting and diarrhea, we think about hypokalemia. Okay? We should not think about hyponatremia. Hyponatremia is induced by our bad therapy, by our bad management. Does traditional blood gas analysis serves the purpose? We are looking at the pH, we are looking at the PCO2, we are looking at the PO2, and we are looking at the bicarbonate. What does information it gives? It gives you information of acid-base status, oxygen uptake, carbon dioxide production, and acidity or alkalinity. This is the only information, this ABGs which we have discussed up till now, this is the only information given by them. But what information is required for therapy? What information you want to know for the therapy of the patient? You need to know what is the uptake of oxygen in the lungs and how is the oxygen transported from the lung to the capillaries, and how the oxygen is released to the tissues also. How to get that we'll have to know the deep picture of blood gases. Now if you look at the oxygen traveling from the nose up to the alveoli, from the alveoli up to the blood. When the oxygen is traveling from the nose up to the alveoli, it is all gas. It is passing through. It is a diffusion which is taking place in a gaseous media. Here we apply the Graham's law of diffusion. According to the physics law, in addition to pressure gradient, there is a physics law which is the gases of diffusion in a gaseous media comparatively is inversely proportional to its molecular weight. Molecular weight of oxygen is 32, molecular weight of carbon dioxide is 44. It means oxygen is quicker diffusible through the gaseous media as compared to carbon dioxide because it is inversely proportional. So it means slightly, whenever the patient is apneic or the patient is hypoventilating, put the mask on the face, give oxygen, it will diffuse. But the carbon dioxide will not be able to come from alveoli to the mouth or out to the atmosphere until the person is breathing, unless you help them to breathing, put them on a ventilator. Then from oxygen uptake from alveoli to the blood, to the hemoglobin. Because from alveoli, it is passing through alveolar epithelium. Then it is passing through interstitial compartment. Then it passes through capillary endothelium. Then it goes to the plasma. Then from plasma to hemoglobin. It is all liquid media. It is Henry's law of diffusion. That comparatively, the diffusion through liquid media, in addition to pressure gradient, is directly proportional to its solubility coefficient. Carbon dioxide is much more diffusible as compared to oxygen. So if you combine these both laws together, Graham's law of diffusion and Henry's law of diffusion, the ratio is 20 to 1. Carbon dioxide is 20 times more diffusible from the blood to the nose. So if you look only at from the blood to alveoli, the carbon dioxide is 24.7 times more diffusible as compared to oxygen. But when we are applying diffusion through the gaseous media and diffusion through the liquid media, it is 1 to 20 ratio, right? It is physiological basis. Transport to the capillaries. Once the hemoglobin has been saturated, it is depending on the amount of hemoglobin. So we calculate what is the DO2, how much is oxygen being delivered to the tissues. So we look at the hemoglobin level and we'll look at how much oxygen is combined, how much is hemoglobin saturated. Then we see how much oxygen is present in the plasma under the partial pressure of oxygen. So calculate all that. If you calculate all that, this is called DO2, delivery, which is being given to the tissues. Normally it is 520 to 720 milliliter per minute per square meter. So this is delivered to the tissues in a normal person. Then at the capillary level, the oxygen is delivered to the tissue. That's called VO2, volume of oxygen which is delivered to the tissues. It's about 110 to 160. Out of all that DO2, this much is extracted. So about 25% of DO2 is delivered to the tissue. The rest goes into the venous blood. So you can measure this VO2 yourself also. You take the arterial sample, measure its DO2, then you take venous sample, you measure its DO2 and take the difference. That will tell you VO2. Now, as I mentioned earlier, now this has been delivered, whether the tissues are using it or not. For that purpose, you will have to look at the lactate, whether the lactate is going up or going down. So it means oxygen has been delivered, has been extracted, but it's not being used, as in cyanide poisoning. Cytochrome oxidase, it is suppressed. So unless you have measured up to the lactate level, you have not completed your oxygenation status of a person. What is the deep picture of blood gases? You are required to know the PCO2, required to know total hemoglobin, required to know the saturation, required to know oxygenated hemoglobin, you required to know the total content of oxygen, required to know the P50, and required to know the VO2. So we should have a blood gas analysis in that way that we should know all these parameters. From there we can say, after diagnosis, that this is a therapy which is required for this particular patient. Now, transport mechanism requires the amount of hemoglobin. Greater the amount of hemoglobin, the more will be oxygen carried. And then fraction of oxygenated hemoglobin. Now, we've got hemoglobin molecule, how much area which has been taken up by the oxygen. This is what is happening, we say hemoglobin saturation. Then what is the partial pressure of oxygen? The oxygen which is present in the plasma, it is exerting its pressure, which is called P small aO2, PO2. Because under that PO2 partial pressure, the oxygen has to be attached with the hemoglobin. For that purpose, we look at the oxygen dissociation curve. What is the oxygen dissociation curve? It is the curve which correlates the partial pressure of oxygen with percent saturation of hemoglobin. So when at the level of PO2 at which the hemoglobin is 50% saturated, is called P50. Now, this oxygen dissociation curve can be shifted towards the left, right, or can be shifted to the left. There are factors which we will mention later on. Actually, the major challenge is we have to balance the oxygen supply and the oxygen demand. For example, if the patient has got hyperthyroidism, hypermetabolic states are there, then the oxygen demand is more, but we go on supplying the normal amount, so that will create the discrepancy. So accordingly, you will have to go higher up. So in that purpose, you will have to increase the oxygen which you are giving. You have to increase the transport mechanism, that you have to increase the hemoglobin also. And you will have to keep the hemodynamics normal, look at the blood pressure, because it has to deliver there. Oxygen carrying capacity is 98% is bound to hemoglobin, 2% in the plasma. And it also depends on different forms of hemoglobin. Oxygenated hemoglobin is OHB. Deoxygenated hemoglobin is RHB. And then there is dyshemoglobin, that is carboxyhemoglobin and methemoglobin. Now this if you look at this, deoxygenated, we know there is no oxygen on the hemoglobin. What is carboxyhemoglobin? The carbon monoxide combines with it. What is methemoglobin? Methemoglobin is oxidized hemoglobin. The oxygen, this saturated hemoglobin is when their oxygen goes and sits over there. There is no chemical reaction. When there is a chemical reaction, so it is called oxidized hemoglobin. So when there is simple saturation of hemoglobin, so it can easily be unloaded. But when there is oxidized hemoglobin, methemoglobin, we'll have to reduce the reaction by giving reducing agent like vitamin C and other things also. So you calculate all together, it becomes a little bit complicated. Now, oxygen content depends on the total hemoglobin, oxygenated hemoglobin plus partial pressure of oxygen plus coefficient. So, if there is a problem with oxygen content, you look at the hemoglobin, whether the amount of hemoglobin is normal or not, or whether there are dyshemoglobin present or not. So, you correct both. Then oxygen saturation, you look at what FiO2 you are giving to the patient. Then you look at what are the factors which are affecting oxygen saturation. Then you will have to look three factors which affect the oxygen dissociation curve: temperature, acidity or alkalinity, or 2,3 dpg level. So you can easily analyze them. Very easily you can measure the 2,3 dpg also. Oxygen release. Oxygen release, you will have to look at the hemoglobin oxygen affinity. Then you have to look at what is the capillary PO2 and the tissue PO2. Because things always flow, whether it is a liquid or a gas, the things always move due to pressure gradient, from higher pressure to lower pressure. If you put a water here on the floor, have you ever seen the water going into the pillar? No. So if it is one thing side high like this, so it will be going from higher side to lower side. So it is a gravitational effect which causes movement of the liquid or gases. Then there are some additional factors also for diffusion. Those will have to look what is the pressure of oxygen at the tissue level and what is the pressure of oxygen at the capillary level. It has to be different. See? That's one of the reasons why the carbon dioxide comes from the tissue and goes into RBC. Because RBC doesn't produce any carbon dioxide because nature has not put mitochondria there. This is the reason why the nature hasn't put it there, because if there would have been mitochondria in the RBC, would have died in the uterus, because there will not be any pressure gradient between the plasma PCO2 and the RBC PCO2. So due to pressure gradient, the carbon dioxide goes into the RBC. Now this is a typical example of oxygen dissociation curve. It's badly drawn because I didn't know how to draw it. I just put the lines on it. Now if you look at the center red one is the normal oxygen dissociation curve. Right. So if it goes down like this, so it means it is moving on the right side. Then when it goes like this, it's going on the left side, oxygen dissociation. So the movement depends on three factors. As I told you already, it depends on acidity or alkalinity, temperature, and then 2,3 dpg. Excess of everything, hydrogen ion excess, temperature rise, or excess of 2,3 dpg will shift the curve towards the right. It means it will easily unload and it's very difficult to saturate the hemoglobin. So it means you will have to give high PO2 to have the same saturation. So P50 will move towards the right. On the other hand, if there is a 2,3 dpg less, there is a hypothermia and there is alkalosis, it will shift towards the left. So if the person is hyperventilating, it goes into alkalosis, the curve has shifted towards the left. Even at low PO2, it is 100% saturated. When it goes, same blood goes to the tissues. If the oxygen dissociation curve has been shifted towards the right, it will quickly give oxygen to the tissues. When this hemoglobin has shifted towards the left, even if this fully saturated hemoglobin goes there, it will not give oxygen to the tissue. So mean purely saturated hemoglobin is useless for us unless it is in a mood to give the oxygen to the tissues. Now this, if you look at this diagram, if oxygen is normally carried by the blood hemoglobin, but there is a myoglobin in the muscles also. Instead of carrying 4 molecules, they carry 2 molecules of oxygen. Where should be the curve of the myoglobin?
Left side.
Will it be on the right side of the normal curve or left side of the normal curve?
Left side.
It will be on the left side because it has to extract the oxygen from the tissues. So the myoglobin curve will be on the left side. Where will be the curve of a baby in the uterus? Left side or right side of the normal curve? Mothers, if you got a mother's curve, now it will be lying on the right side or left side? It should be on the left because it has to extract the oxygen from the mother's blood. These are very typical YOC questions I used to ask in fellowship. You draw the 3 curves: myoglobin curve, normal curve, and then curve of a baby in the body of uterus, right? D picture contains information on oxygen uptake, transport, and release. That completes our oxygenation status. A 60-year-old woman presents with pneumonia, shock, and respiratory distress. ABG shows FiO2 50%, PCO2 30, PO2 10 and 5. 10.3, base excess is 183. Then 3 questions are being asked. Describe acid-base status. Is there a problem with the oxygen transfer? Is intubation likely to be necessary? This is important, very important scenario. 99% people fail on it. Go and think about it. Tell me next time if anybody answers this question. Okay? You are asked to see a 15-year-old asthmatic male having treatment in accident emergency for the last 3 hours, having low PCO2, and now tachypnic with mild wheeze. Right? pH is 7.5, PCO2 is 30, bicarbonate 23.1, FiO 2.5, PO2 80, base excess minus 1.5, sodium 143, chloride 105. After the therapy, pH is 7.39, and then this PCO2 30, bicarbonate 7.9, FiO 2.5, and then PO2 is 175, base excess minus 7.9, and sodium is 143, chloride is 105. Now, question on this is, calculate and interpret AA gradient. Describe the acid-base status. Has his asthma improved? Give your reasons. What is the most likely explanation for the unchanging hypocapnia? Right? These are something to think about it. I'll give you the handouts. It's all written there. And it has given an answer also there. But try to analyze yourself first to check your understanding. So if there's any question on that, ask me next time when you come. Right? I've got more histories also in my book. I've given the books also last time. Read all that and that acid-base disturbance. Anion gap. Last time Dr. Amar acknowledged, I don't believe in it. It's all rubbish. Because it's only related to metabolic acidosis. And there are 9 causes of metabolic acidosis. There is not even 10th cause of metabolic acidosis. And if you can analyze, if you look at the acid-base status of a person, look at the potassium, look at the chloride, and look at the glucose level, and look at the renal parameter, you can analyze all those parameters. But anion gap, what does it tell you? It is the difference of cations and anions. Commonly is the sodium minus chloride and bicarbonate. So this is anion gap because the anions are less, that's why it's called anion gap. So sometimes with potassium, some people calculate. And hypoalbuminemia, so that also negative ion. So this gap becomes less. So just remember those few things and read in the book, because I don't practice it, but I've written here, I've written in the book also. So normally we only take the positive ion sodium, then we take the negative ions, which is bicarbonate and chloride, and take the difference. And that should be a difference of 6 to 13. If you include potassium in it, then the difference can go up to 20 millimole. Then some people classify it: normal anion gap, high anion gap, normal anion gap, and low anion gap. So हम अपने आप को मुसीबत डालते हैं इन चीज़ों में पढ़ने के बाद. So if the proteins are level or paraproteins are high, so then the gap becomes less. So something like that, confuse होकर बैठ जाते हैं. तो इनकी यूज़ को नहीं. फिर एक और इक्वेशन निकाली है, this is called delta ratio. Delta ratio is if there is a mixed mixture. So they use the anion gap with they calculated delta ratio. Delta ratio is nothing but anion gap minus 12 divided by 24 minus bicarbonate. And if delta ratio is up to 0.2, 0.4, 0.4 to 0.8 or greater than 2, then do the non-anion gap metabolic acidosis or anion gap metabolic acidosis, then go on classifying like this. So personally, I don't indulge into these things, and you can answer all the questions without indulging in these things also. But otherwise, there is no limit. People have calculated so many other things, formulas also with it. But simple thing is, you assess only three things: acid-base status of a person, but you know the causes. Then you look at the oxygen status of the patient. Then you do the oxygen delivery to the tissue also. What are the factors which affect? Thank you. Thanks very much.